my information. Dr. Rita Bell Fernandez is an associate professor at the Geriatric Medicine Department at the John A. Burns School of Medicine, University of Hawaii. She is a practicing geriatrician with Kalihi Palama Health Center and a medical director for Bristol Hospice. She is also a certified trainer of the National Task Group on Intellectual Disabilities and Dementia Practices, or NTG curriculum. It is with my honor that I turn today's presentation over to Dr. Rita Bell Fernandez.
Mahalo, everyone. Thank you for the kind introduction. Appreciate it, Abigail. Thank you to all the waiver providers, caregivers, and families that have joined us for this webinar this morning. I know we have a lot of people that have signed up, and I thank you for taking the time to learn more about this topic and to improve the lives of your loved ones. So let's begin. I hope I'm moving the slides. Okay, yes. All right. I would like to convey our thanks to the Administration on Community Living, which awarded a federal grant to Catholic Charities. And it is through this grant that we're able to bring the training, and we have mentorship from the NTG group, which are our grant advisors, and they are helping us roll the curriculum out in different states. And in Hawaii, they are our grant advisors. So why are we doing this topic? You know, we used to think before that the life expectancy for somebody with developmental disabilities, intellectual disabilities was not that long. But the whole world is aging and everyone is living longer. The countries with the longest life expectancy is Japan, Singapore, Macau. They have much higher life expectancies. US is also higher up there. So as everybody's living longer, we notice that even people with, say, Down syndrome is living longer. The whole world is aging and life expectancy has increased. So who is this NTG group? The NTG stands for the National Task Group on Intellectual Disabilities and Dementia Practices. This is a coalition of interested persons and organizations. It is comprised of physiatrists, doctors, social workers, nurses, people in the advocacy line. Whole mission is to ensure that the interests of adults with intellectual and developmental disabilities who are affected by Alzheimer's disease, as well as their families, are taken into account as part of the National Alzheimer's Project Act. So now it is in law, it's in the NAPA law. And part of this is any states receiving federal grants or federal funds for dementia need to address the group that is involved with developmental disabilities and intellectual disabilities. They have a website, the ntg.org. So please look at this website if you'd like to access resources and take a look at what they are doing currently. So how much is this risk? If we are looking at dementia in the population, most adults with intellectual disabilities are typically no more at risk than the general population. So you're talking about, it's similar to grandma and grandpa, which is, if you're over the age of 85, it's 1 in 3 persons. If you're over the age of 65, it's 1 in 9. So they match the general population. The adults with the greatest risk is adults with Down syndrome. And in them, you will notice dementia appears earlier in their 40s and 50s, and you are also seeing a more rapid progression. So this is another slide showing the prevalence of dementia. If you see in Down syndrome, age 40 and over, it's about 22%. And if you go age 60 and over, it's more than half that have dementia. Okay, what about the general population? As I mentioned, 1 in 3 seniors over the age of 85. And we're looking at Alzheimer's disease currently is presently about 5 million. But as the population is aging, this is projected to reach close to 14 million. And we do feel that these numbers are underreported. So even though we're saying 5 million right now, I do not believe there's only 5 million Americans living with Alzheimer's presently in the United States. Okay, let's look at Hawaii. What about our rates in Hawaii? How many persons do you think have dementia here in our state? It's close to 30,000, but even this number seems far lower than what we think, because people might not have the diagnosis. It may not be written in their chart. Maybe it's just memory loss is written in the chart. So you need to look at Alzheimer's disease in Hawaii is actually far more than what the numbers and the fact sheets tell us. So we're thinking this is the tip of the iceberg. What figures we have does not include those who are undiagnosed or underdiagnosed. And that is like an iceberg, 60 to 80% are going undiagnosed. And there's multiple reasons, multifactorial causes about why it's going undiagnosed. Maybe the doctors have no time. The visits are only, 15 minutes in an office. You're in and out so fast. They're busy addressing diabetes, blood pressure, and other problems. And often dementia is forgotten. Also with families, people think that, oh, grandma's just getting old, or mom is just, it's old age. And often dementia is missed. So what is Down syndrome? I want to just do a little refresher. I know many of you are very familiar with this topic. It was first described by an English physician, John Langdon Down, in 1866. It is a developmental disability that includes both intellectual and physical abnormalities. It's also known by another name, trisomy 21, because there's a full or partial copy, an extra copy of chromosome 21. Now, on this chromosome sits something called the amyloid precursor protein. We all have the amyloid precursor protein. And that gene for that protein is on chromosome 21, which is why, since there is a whole extra copy of this chromosome, there is more beta amyloid forming in the brain. The physical characteristics of Down syndrome, many are very familiar with this. The slant in the eyes, there's a single crease across the palm, and you will notice smaller stature, low muscle tone. This is karyotyping. Karyotyping is how we look at chromosomes, and it's showing you how for 21, there's 3 copies here, which is circled in red. Besides dementia, you're also noticing other conditions. There is premature aging in Down syndrome, so they are at increased risk for heart disease, cholesterol problems, bone, osteoporosis, all the diseases that you think with old age is occurring about 20 years earlier than the general population. Now, many people ask me, what's the difference between dementia and Alzheimer's disease? Are they one and the same? So I bring you to this example. Think of the flower world. There's so many beautiful flowers in Hawaii, right? We have orchids, plumerias, hibiscus, bird of paradise. But I might say plumeria is very common. I look to the house on the right, I see plumeria. I look to the house on the left, there's more plumerias. So plumeria is probably the commonest flower on the island. Similarly, in dementia, there are many types of dementia. Dementia can be viewed as an umbrella with many causes. So you have causes like dementia can occur because of strokes. That's vascular dementia. You could get dementia from severe alcohol use, from Parkinson's disease, Lewy body dementia. People who are boxers, NFL players, they get head trauma. You can get dementia from head trauma. But the commonest dementia, the commonest type is Alzheimer's disease. And how common is this? It's about 60 to 80% is Alzheimer's disease. Typically in brain conditions, we do not do biopsies. So we all have a hard coconut and there's no easy way to reach our brain. So these slides, what I'm showing you is typically done on autopsy. That is after a person has passed away. These cells are then looked under a microscope if an autopsy is ordered. And you will look at what a healthy brain cell looks like. It's very different from cells with Alzheimer's disease that has this amyloid plaques and tangles in the brain. Alzheimer's dementia is the most common one. It is gradual in onset, and it typically affects short-term memory. So they may remember stories from long ago, their childhood, but the short-term memory, like what did you eat for breakfast, they have forgotten. And there is generalized shrinking in the brain, which is also known as cerebral atrophy. I'm going to try to play a video for you. Please let me know, Abigail, if we can hear this video. Let's hope. Otherwise, you can play it from your end. Abigail, maybe we go back a slide and see if you can play that.
Let me go ahead and take care of it.
Thank you.
What is Alzheimer's disease? Alzheimer's is a slow, fatal disease of the brain affecting 1 in 10 people over the age of 65. No one is immune. The disease comes on gradually as 2 abnormal protein fragments called plaques and tangles accumulate in the brain and kill brain cells. They start here in the hippocampus, the part of the brain where memories are first formed. Over many years' time, the plaques and tangles slowly destroy the hippocampus, and it becomes harder and harder to form new memories. Simple recollections from a few hours or days ago that the rest of us might take for granted are just not there. After that, more plaques and tangles spread into different regions of the brain, killing cells and compromising function wherever they go. This spreading around is what causes the different stages of Alzheimer's. From the hippocampus, the disease spreads here to the region of the brain where language is processed. When that happens, it gets tougher and tougher to find the right word. Next, the disease creeps toward the front of the brain, where logical thought takes place. Very gradually, a person begins to lose the ability to solve problems, grasp concepts, and make plans. Next, the plaques and tangles invade the part of the brain where emotions are regulated. When this happens, the patient gradually loses control over moods and feelings. After that, the disease moves to where the brain makes sense of things it sees, hears, and smells. In this stage, Alzheimer's wreaks havoc on a person's senses and can spark hallucinations. Eventually, the plaques and tangles erase a person's oldest and most precious memories, which are stored here in the back of the brain. Near the end, the disease compromises a person's balance and coordination, and in the very last stage, it destroys the part of the brain that regulates breathing and the heart. The progression from mild forgetting to death is slow and steady, and takes place over an average of 8 to 10 years. It is relentless and, for now, incurable. Helping your family, friends, and neighbors to better understand Alzheimer's will reduce stigma, improve care, and even help the fight for a cure. Thanks for helping to do your part. Learn more at www.aboutalz.org.
Thank you, Abigail. I'm glad you all got to watch this video. It explains the stages of Alzheimer's disease very well in the video. And it also explains why families think, oh, grandma and grandpa are doing so fine. So I had a family that told me, Dr. Fernandez, Nana's awesome. Her brain is awesome. She can remember all these old things when she was a child in the Philippines, how she grew up with her grandparents. And Nana was telling the family all these old stories. But of course, she has forgotten what was just told to her recently and asked the same questions over and over again. So you see in that video, it shows you that the oldest memories is the last to go, which is why families often may get misled because they think that, oh, someone reminiscing and telling the stories from the old days is actually a sign of a very good brain or very strong brain, but it is the remote memories are last to go. Now let's look at how Alzheimer's disease presents in Down syndrome. It actually presents differently. It may not present classically as, oh, I'm forgetting things or asking the same questions over and over again. You might see things like new onset seizure activity when there was none in the past. You might see incontinence when somebody has been independent in toileting. The short-term memory loss, which is the classic sign of dementia, is very variable, and it depends on the person's baseline and their previous demands and reliance on memory in everyday life. So it is highly individualized. Another change you might notice in Alzheimer's disease in this population is sleep-wake cycle disruptions. So the presentation is unpredictable and unique to each individual. Okay, yep. I'm still struggling with these buttons at the bottom. Okay, here we go. So dementia affects all aspects of functional ability. It's not only limited to memory. Memory is one aspect. It affects language, it affects judgment, reasoning, sensory perception, ability to sequence tasks, ability to focus and pay attention. Often it may not be the memory that goes first. Sometimes you might think, why is the person doing something so silly or exhibiting such poor judgment? And that may be a sign of dementia. Next challenge we have is that the traditional screening tools that you are a bit familiar with are not useful in this population. So what are the tools that are out there? You may have heard of draw a clock, the clock drawing, or who is the president, what day is today, or what year is it? All those traditional screening tools that are designed for general population are not useful in detecting cognitive impairment in adults with Down syndrome. So an alternative tool has been advocated by the NTG, and this is one of your handouts. I hope you have received it. If not, we're going to put it in the chat, the EDSD screen. And I'm going to spend some time discussing this. EDSD stands for Early Detection Screen for Dementia. It is adapted from two other earlier questionnaires and screening tools. The EDSD is 6 pages long. You are to begin administering it at age 40 for persons with Down syndrome, and then annually. For non-Down syndrome, you can begin at age 50. It has been translated into multiple languages, which you can find on the NTG website. Let's look at the different sections. So the first section, page 1, has the basic diagnoses, living arrangements, where's the person staying. Page 2 also has basic information. Page 3 and 4 is about function. It's looking at memory, their behaviors, their mental state. Page 5 has comorbidities, like is there epilepsy, other issues, blood pressure, diabetes, all other coincident conditions. Page 6 is listing the memory medications and other comments. So those are what the 6 pages have in them. So the key sections are demographic, rating of health, mental health, and life stresses. The review of multiple domains include the activities of daily living, language and communication, sleep-wake pattern, ambulation, memory, behavior, and effect. And then we have chronic health conditions. I want to draw your attention to page 2, block 14. Block 14 has life stressors in the past year. It's important to note whether there was any death, whether the person, has a new roommate, a new group home, was moved, whether there was any other stressors, because it may not be dementia, it could be depression, it could be something else going on. So pay attention to block 14. Often I'm asked, who can complete this form? Do you have to be a doctor, a nurse, a social worker? Actually, according to the NTG, anyone can complete the form if they have known the person for a minimum of 6 months. So if you are familiar with the person and you have access to information, yes, you can help filling out the form. So the direct support worker could help fill out the form. The waiver supervisor can fill out the form. A caregiver can fill out the form. A parent can fill out the form. And you may need the chart to complete all of it, because the chart will have other diagnoses and medicines and all that, which can be put in by the supervisor. So we have to look at multiple sources of information, speaking with family, looking through the medical records, through their program plans, personal files, and ask friends and close persons. Another recommendation from NTG is to take a short digital video of a person performing a task. Maybe the task is putting on a shirt, or the task could be eating their food. Just taking a video of that is helpful, because you could then see through the video if there has been any deterioration in doing a particular task. Next, if you've done this form, what happens next? So one thing I would like to bring to your attention is, in this form, there is no score. And we're so used to adding points. Like every screening tool that I do in the general adult population and elderly population, we're giving 1 point, 2 points, and we add up the points. In the NTG EDSD screen, you will notice that there are no points. And the reason for this is because each individual is unique and different, and you are comparing them to their own baseline. So the only way this form is valuable is if you do it the subsequent year, and then you notice change. So we are looking for change from baseline. Once you've done the EDSD, review the form, talk it over with the key players on the person's team. Maybe it's their case manager, the supervisor, the nurse, and see if there are any concerns. If there are concerns and things that have changed, then it is good to make an appointment with the provider to get the person further assessed. So the PCP can do this And a part of our grant is also we have gone to grand rounds to train doctors and let them know about the form, about the EDSD scale. Bringing this to the attention of the provider is key, because then they can do the necessary blood tests or other tests required to further investigate, is this really dementia or is it something else? So what is part of the workup? And I know this list is looking very long and scary. I've had some caregivers tell me there's no way my son or daughter is going to agree to any of these tests. And I know it's very challenging to draw blood and do immunization and all of this in this particular group. I want you to know, though the list looks long, it's one poke. If the person can have one poke, 3-4 tubes is collected and it's sent out to look at, say, vitamin B12 levels. You can have memory problems from low B12. You could have memory problems from thyroid. If your thyroid is working poorly or under, people can have memory problems. Celiac disease is another thing that can mimic memory problems. So the blood test helps to rule out these conditions. Part of the workup is, doing a good history, reviewing all the medications, taking a full history physical, including, a neurological exam, a psychiatric exam, and if possible, to do a CT or an MRI. And I know this may never happen. This is extremely challenging, and it's not mandatory. You don't have to do this for the diagnosis, because largely dementia is a clinical diagnosis. One of the things that the providers, I'll go back, have to keep in mind is the 3Ds. What are these 3Ds? They kind of mimic each other: dementia, delirium, and depression. So anytime somebody comes with memory issues, we cannot just say it's dementia, because somebody could have memory problems because of depression. Maybe they're just so sad that they have forgotten, or they don't even care to remember. Depression is unexplained change in mood that occurs over weeks. Delirium is very different. It is abrupt confusion, forgetfulness, maybe agitation. It's sudden and it occurs in hours to days. Often when there's delirium, there's some underlying cause. There could be a UTI, a urine infection, a pneumonia, could be COVID, could be something is causing that delirium. And here blood test is of great value, because you can detect some abnormalities in the electrolytes, in the kidney function, liver function, etc. Dementia, on the other hand, is a very gradual disease. It's over months to years. So Alzheimer's is very gradual, versus delirium is most abrupt and sudden. I wanted to show you a photo of the CT scan just to see what goes on in the brain. On the left side of your screen, you're looking at a healthy brain, an aging senior's brain. And you can see there's a lot of white matter, that is the brain cells. And this red, blue, and green is the hippocampus. That is the memory centers in the brain. Now, if we look to the right, you will see this brain, there's a lot of black areas. So the brain is shrunken, and the black areas that we are seeing is actually fluid in the brain. It's called cerebrospinal fluid. So that has increased. The brain has shrunk, and those red, green, and blue areas have become even smaller in this brain. So the right side is the brain of person with Alzheimer's disease. The left side is just normal aging. What are the medications for Alzheimer's disease? Is there any cure? I know there's a lot of things in the news now, medications, injections that can clear the amyloid plaques. So far, they are not approved by insurance, so it's not something that we can just go ahead and order as of today or this month. But what's available right now in the market that's covered by medical insurance are drugs like Aricept, Namenda, Exelon. You may have heard of a combination called Namzaric. These drugs are helpful for moderate to severe Alzheimer's disease. Sometimes you see more effect on behavior, especially if people have agitation. Maybe Aricept is more helpful. But they have limited benefits on the memory. So taking these pills doesn't greatly improve the memory. Suddenly they're not going to become Einstein or remember stuff. So the effect is very modest. How did the drugs come to market? They came to market because the FDA approval said they can delay nursing home placement. So they can delay nursing home placement by 6 months to 12 months, but no big dramatic effect you're going to see on the memory. So what can we do then if the medications are just very mild to modest effect? You have a big role to play. You as a caregiver, as a direct support worker, as a supervisor, as a waiver provider, you can advocate for this person. Along with the team, you want to make sure that they get the best care, and all different things are covered with dementia. And I'm going to go through what are the other things that we can do to improve the quality of life. So 4 steps in health advocacy is first observing. You observe. If you notice some change in the person, report it, let somebody know, and then prepare for the health appointment and follow up if there are things that need to get done, follow up after the appointment. One family member told me, Dr. Fernandez, my son was very OCD. He used to put his toys and cars and toy trucks and toy cars all in a perfect line, perfectly ordered by color and everything. And this was for years and years and years, and that was the baseline of this child. And as he grew up later, how the parent realized, they observed that this child now, who was so meticulous and so precise in how everything was arranged, suddenly didn't care how the toys were. Suddenly they was, it was untidy. It didn't look so in place and perfect. And that's when the mother says something is wrong. That's when they got a clue that probably we need to look into this. So first is observation, then it's reporting, and then you have to bring these concerns forward. So caring for someone with dementia requires a shift in thinking. In the medical model, we are very focused on rehab. You break your hip, you go for rehab. People have a stroke, they go for rehab. Drug and alcohol, there's rehab. But in dementia care, we have a new word, and the new word is habilitation. Habilitation is the term used by dementia professionals to describe what are the non-medical interventions that are best practices, because we want to maintain function, safety, and comfort. So the person can age in place as best possible. So some of the key concepts are, let's try to maintain support. Should we redirect this person? What about, should we orient them or not to orient them? Can we validate them? Can we look at their life story? These are some of the key concepts in dementia care, because as I told you, the medicines, it's not like a blood pressure medicine where you take a pill and that blood pressure will come down pretty much, or you take a diabetes insulin and your blood sugar is going to come down. The pills that we have right now for memory doesn't make people remember stuff. So we have to look at all these other things to improve dementia care. So I'm going to start with the first one, maintaining support. It is best practice in dementia care. It can be done anywhere, in any setting. It's a proactive approach. So what we are focusing on is supporting the remaining abilities. Supporting the remaining abilities is looking at the glass is half full. We are not looking at the glass as half empty. It's what they can still do. And if we provide meaningful, failure-free activities, engage the person, they can be supported and continue to live where they are for a long period of time. We can help reduce and eliminate difficult behaviors. And this can be done in all settings by all staff. So you're focusing on the remaining abilities and not on the losses. Another key concept is life story. Everyone has a life story that needs to be honored. And this is the essence of the person, which is why, Didi, when patients are in foster homes, care homes, they are very particular to make sure that, the room, the persons have a right to decorate the room the way they want. They can have their photos up, their certificates, Special Olympics, their medals can be displayed because each one has their story. And sometimes what happens is person's story is lost in the shuffle, especially if they're moved and maybe they were on a neighbor island and then they had to come to Oahu, or maybe they got hospitalized and now they cannot go back to that home, they're going to another home, or the roommate changed. So there's so many things where the stories get lost, and we need to try our best to honor a person's story, honor them in calling them the name that they want to be called. Some people have a preferred name. Please use that preferred name. Another approach that is strongly advocated is the validation approach. This focuses on empathy and understanding and is based on the principle of validation. Using this, we can reduce stress, agitation, and the need for medicine. Because the first time people have difficult behavior, it's like the care home operator will call me and say, "Doctor, can we have a medicine?" We don't need medicines for challenging behavior. We need to think of these other approaches. Can we change our approach that then the person will not get angry, upset, and agitated? So I want to give you an example of validation. Let's look at this example. John says, "Someone stole my book," and he's banging on the table and he's really mad. Now, one answer is, "John, you're so careless. You're losing your book all the time. Don't blame other people." So that's one answer. In the validation approach, you are actually joining the person on their journey. So what you would say to John, an example of a validation approach is, "I'd be upset too if that happened to me. I'll help you look for it." So validation can be done to all persons. We can join them in their journey and reach them at their level. Next key concept is, should I orient this person or not to orient this person? The best practice in dementia care today is do not try to correct or reorient the person. And this is really hard, especially for staff, because they're worried about HIPAA and patients' autonomy, and patients should be told everything. In dementia care, we look at it more that we are joining the person we're entering their world. We don't have to bring them to our world. We're going to their world and we're joining them in their journey. So let's look at this example. "What time is my mother coming?" And Ken's mother died 20 years ago. Which response is better? A, "Your mother is dead, Ken. Your sister will pick you up at 4 o'clock. Or the B answer is, "She'll be here in a little while. Let's get a cup of tea while we wait." In today's best practice of dementia, B is the right answer. B is the kinder, better choice of the answer. Because if you remind the person of their mother's death, which they have forgotten. They may grieve and start crying again and go through bereavement again. And some family members do another thing. They start quizzing. Who is this one? Who is she? Who came today? What day is today? And trying to reorient the person in what day, what month, what year often may increase their frustration and anxiety and agitation. So the better approach is not to reorient them and tell them today is February 2022, year of the tiger. I don't need to tell them any of that. It's better to join them on their journey, and using photo albums, reminiscing is a more appropriate kind of approach. Another key concept is distract and divert. So what do you do when somebody is banging the door? What would you do? You would have to say, hey, I don't want to tell them stop doing that. Excuse me, I'll be right. Just give me 1 minute, please. My apologies, I'm back. So distract and divert. In distract and divert, it's easy to change the agitated behavior. Instead of saying stop doing that or don't do that, you can distract the person and divert their attention. So let's look at this example. It's 4 a.m. and raining. Harry wakes up and wants to go outside for a walk. What should you do? You could say, are you crazy? It's 4 a.m. I'm not going to go for a walk. But a kinder, sweeter answer is this. Sure, let's go for a walk. But before we go, I need to have a snack. My favorite snack is ice cream. What's yours? In this way, we can refocus their attention and redirect behavior. Remember, all behavior is communication. So when someone is agitated or hitting or banging on the table, they are trying to communicate something. And we need to be a detective. We need to think like a detective, be a detective to figure out what's causing this. Behaviors are often triggered by, it could be caregiver interaction, there could be pain, there could be frustration because the task was too difficult. It could be the environment. There's a whole host of things that could contribute to a challenging behavior. So one has to think more like a detective. In dementia, we tell the caregivers to please try to communicate slowly and clearly using short, familiar words and phrases. Give adequate time to respond. When we are giving a task, try to break the task down into simple tasks. Like take a bath. There's so many steps involved in taking a bath. If you can break that down, that's very helpful. Ask one question or give one direction at a time. It's instead of saying, what would you like for lunch? You could say, Mary, would you like a chicken sandwich or a fish sandwich for lunch? Use the technique of join, validate, distract. Remember, routine and consistency is very helpful and calming to both the person with dementia and those around them. So try to have some structure to the day, having lunch at a certain time, certain outings, planned activities, because all this routine is helpful. When we're giving somebody a task, remember, in the early stage of dementia, they can do a more complex task, but in a later stage, you must greatly modify the task. And that is important because we don't want to tell the person to stay in your room or don't come out. You want to involve them, but try to modify the task. Adapt activities so that they're failure free, that they meet the needs and the capacity of the person. So you can greatly simplify a card game. You can change the rules to mahjong. You can play it differently. You just adapt the game such that person is enjoying and it's failure free. Here's an example of right sizing at the activity. Now, imagine I have my neighbor's kids for the weekend and I agree to babysit them. And one is 5-year-old, 10-year-old, and one is 15 years old. So I decide, let's do an activity. Let's make chocolate chip cookies. Everybody wants to make cookies. So what can I give the 5-year-old to do that is task appropriate? Maybe they can roll the dough into small little balls. Maybe they could stir. The 10-year-old, what could the 10-year-old do? The 10-year-old could measure and put all the ingredients in the bowl. What could the 15-year-old do? I can again modify the task to that stage of the person. The 15-year-old could handle the oven, put the cookie tray in. So this is just common sense, and we do this every day. Similarly, for people with dementia, as the dementia progresses, you need to modify your task and activity so that it's still meaningful and not boring and not frustrating. Environment is something the NTG focuses on because environment plays a big role in people's behavior and people's quality of life. So look at your space. Look at the space on the house and see the lighting. Look at the noise. Look at how many people are in the room. Are there any cues? Are there any pictures to find the way? Like, is there a picture for the bathroom? That might be helpful. Otherwise, all doors in the house are white. People can get lost. So when you want to maximize location and function, you can use pictures on doors. A simple thing like a red toilet seat is adding contrast and color, because in the toilet especially, everything is white. But a simple fix could be a grab bar in a different color or a toilet seat in a different color. Here is one, you see the difference between the two toilets? Just a simple thing like a seat cover change adds that color and contrast. You could use the blue Clorox and change the color of the water. That also helps in people seeing contrast and depth perception, because vision is affected in dementia. Some people with dementia have wandering issues. So what can you do for wandering? We want to promote exercise. We do not want to restrain the person. Please don't use restrain. We want to promote exercise. So think of dance, think of radio, think of music. You could disguise the doorknobs, disguise the doors by painting them the same color as the walls. That might help prevent wandering. There's a beautiful program from the Alzheimer's Association called the Safe Return Program. And in that program, they have people who are wanderers. They are put in a database so that the first responders can look for them right away. You don't have to wait 24 hours for a person to be declared missing. They can search for the person immediately. This costs approximately $50 a year, but is well worth it if you are worried about somebody who is at a wandering risk. Dementia and vision. Dementia affects vision greatly. I want to show you this. Put your hands in front of your eyes like a binoculars. Okay, think you have binoculars in front of you. This is what happens to people with dementia. They lose their peripheral vision. So to see right, they have to turn their whole head right. To see left, they got to turn their whole head left. So do not talk to the person from the other room. You have to come in front of the person. Don't talk from far away from the side, because they lose a lot of their visual field and depth of perception. So that's why these color contrasts make a difference. Here's an example of a group home of a person with adult with ID. You can see the glare. You can see everything is so dark colored. What could you do? Instead of changing, saying, I'll change the floor, maybe easier to change the couch, right? I could go to Costco and get a new couch today, far easy. You could have the blinds in a darker color. You could have curtains to reduce the glare. So simple things can be done to make your environment more friendly. Here is an example of nursing homes or care homes. You might see everything in white. A simple fix to this, and we worry about why people are losing weight. A simple fix is you can have a table mat, a place mat in a different color, and that can add some color contrast. I want to end with caregivers, because this is we're coming to the end of my talk, and this is one area where people have a very heavy burden of caregiving. The life expectancy of persons with intellectual disabilities rose from 18.5 years to 66.2 years. So in the old days, the doctors told the parents and families that your loved one is not going to live very long. Maybe just as a young adult, they will pass away. But now they're living longer. So where are they living? They're not institutionalized. Majority of people are in the community, in the homes, in residential facilities. And parents themselves have their own health issues, their own aging issues. Remember, parents with a child with ID have a lifelong career of caregiving. It goes on for years, which is very different from the general population, where somebody might come home to the islands to take care of mom or dad. They may give up their job or change their life for 3 to 5 years, but it's different for parents with ID. So they're at very special risk because they got their own health problems, and they're worried about who is going to care for their child when they die, who's going to pay for it. So care plans, when case managers, we need to include these questions in our long-term care planning documents. I do have this one handout for you. In addition to the EDST handout, it's the MIND diet. Please look at this MIND diet, because caregivers ask me, what can I do for my loved one? And cooking some good healthy food is helpful to slow the progression of dementia and make their brain stronger. The MIND diet stands for Mediterranean Intervention for Neurodegenerative Delay. So it's essentially the Mediterranean diet. So extra virgin olive oil, vegetables, fruits, nuts, all good stuff. Keep the the fried foods, the red meats to a minimum. But you can use extra virgin olive oil instead of butter or margarine. Another handout we have for you is 10 ways to love your brain. What's good for the heart is good for the brain. So getting enough sleep, exercise, learning something new, all of these things help the brain. Please look at this handout. You can give this to families. And I will end with some resources. We have Catholic Charities, Alzheimer's Association, the ADRC, the DDD division. They are all there to help. You don't have to have the diagnosis of Alzheimer's to reach out to the Alzheimer's Association. Anybody with memory problems can reach out to them. I'm open for questions now. Oh, one more thing. We must not forget end-of-life care. Everybody merits hospice care towards the end of life. So persons with Down syndrome or cerebral palsy or quadriplegia, paraplegia, we need to think about good end-of-life care. In the end, it's you that plays the biggest role, because the patient may not be able to speak for themselves and advocate for themselves. So you, as the caregiver, as the supervisor, as the waiver provider, can bring the best healthcare to the individual. Healthcare is an art, not a science. And I will be happy to take questions. You can type some questions in the chat if you like, and Abigail can read out the questions.
Awesome. Thank you so much, Dr. Rita Bell. Like what Dr. Rita Bell mentioned, we can go ahead and open the floor to questions. If you are unfamiliar with our question and answer, depending on if you are joining on an iPad or a computer, it'll be located on your Zoom toolbar. In the meantime, in the chat, we will be providing you with the handouts that Dr. Rita Bell has mentioned today. Her slide deck, along with the screening tool and the Mind handout, is coming your way. If you are not able to download it through the chat, we will be sending you folks to a link where you can download it onto your computer directly. All right. So again, do we have any questions? Looks like everyone is good to go. Thank you so much, Dr. Rita Bell Fernandez, for joining us today. And we'd also like to thank you for joining us for this month's installment of DDD's First Tuesday training series.